Good morning. It's Thursday, January 28th. Can't believe that we're almost a month into 2021. You're here with us with The Doctor is In, Ask Dr. Already. I'm Sybil Madison, your Deputy Mayor for Education and Human Services, and I'm here with Dr. Allison Arwady.
Good morning, everybody.
You know who she is. She's our fabulous Commissioner of the Chicago Public Health Department. This is where you can get all your answers on COVID and now vaccine. We're very happy that you're tuning in. Those of you who've been here before know that you can put your questions in the chat box below. You can also send them to us through Facebook or Twitter using the hashtag AskDrArwady. So we're going to start by checking our distance.
Looks good.
Even though you've gotten both doses of your vaccine, we still have to do things like watching our distance, wearing masks, and using good hand hygiene, right?
Absolutely, yeah, right. I did get my second dose, if people didn't know that. One of the questions we were getting already was just how was that for me? I had virtually no side effects. You know, we know that some people do have some short-term side effects, but after the first dose, I had just a little bit of a sore arm, like in a way that if I pushed it, I could tell I had gotten a vaccine. After the second dose, really feeling the same way, maybe a little bit of a sore arm, not even what I would really call pain. I have said in a couple of settings that, you know, I am a little tired right now because of other things, but I didn't feel more tired than I have been because of the vaccine. And so, yeah, so I am fully vaccinated at this point. It has been less than a week since that second vaccine, so still that immunity is probably finishing that building up, but
Because it takes 2 weeks after the second
a week or two. I mean, it just continues to build sort of over this time period. I don't think we know for sure at this point that there's a spot in time, but it is, you know, it does build over that week or two, and that's true after both doses. After the first dose, Pfizer or Moderna, it's about half protection, 49, 52% depending, but it doesn't start right away either. It kind of builds after that first dose, and then with that second one after that is when you build up to that 94, 95% protection. But 94, 95% protection still means if I'm exposed to COVID, statistically 1 in 20 chance I still could get COVID. That is an amazingly good vaccine, but it is, you know, we don't have any such thing as a 100% protective vaccine. And so I continue to wear my mask, continue to do the distancing. I've not changed anything that I am doing at this point, and that is really the message, that vaccine is getting added on to our existing mitigation strategies. Like the things we've been doing all along, those actually remain the most important where we're thinking about the risk of COVID and spread in the city.
All right. And I will say that my mom, who's over 65, got her first dose of Pfizer today. So,
all right.
Of course, the texts go, got it. So anyway, she's in Ohio, and she's feeling fine.
Good. And can I maybe just add on to that before we jump in, is that, you know, I know one of the things so many people in Chicago are just, you know, wanting that vaccine, and I'm thrilled that so many people want that vaccine. But just again, let's maybe those numbers right from the beginning, all right?
Yes.
We're getting between 34 and 35,000 first doses of vaccine every week. About half of those are Pfizer, about half of those are Moderna. What does that mean? It means that every day we have fewer than 5,000 vaccines that are available across the entire city of Chicago. And we do not limit it just to Chicago residents. We have an agreement with Cook County, the region. We know that people live and work in different areas, and so we've not said you have to be a Chicago resident or a Cook County resident. We're being very collaborative on this. But that is just not a lot of vaccine. Compared to 360,000 plus Chicagoans over the age of 65, another 350,000 plus who are in that frontline essential worker category. So still, you know, I'm glad your mom's gotten her vaccine, you know, and I'm glad every time I hear about people getting, you know, it makes me so happy every time I hear about anybody getting a vaccine. But we know that probably a lot of you watching are feeling frustrated that you haven't been able to get that vaccine yet. And again, just, you know, patience on that, and that we are getting a little bit of an increase next week, about a 16% increase, which is what the federal government, the new administration had said we would be getting, but that's going to take us up to averaging I think it's 5,700 doses per day across Chicago. So we'll go from a little under 5,000 to about 5,700. Better, but nowhere near where the demand is right now. So,
and are you saying then that it's about 750,000 folks who who are eligible based
eligible.
on 1B opening?
Who are eligible based on 1B opening, not even including the people who are already eligible under 1A and maybe were waiting to get that vaccine. So we have so many people eligible and wanting to get vaccine. And we're working hard to make sure that that vaccine is being directed into especially the areas where we most need it. So just for example, we were, some good news right off the bat before we dive in. We were vaccinating in homeless shelters over the last couple of days, working with partners. Again, we direct vaccine to clinical providers. There's a lot of work behind the scenes to make sure that especially some of these more vulnerable settings, in this case, Lawndale Christian Health, for example, that has been a major partner of ours as we've been thinking about how to support people who are unstably housed. Getting vaccine into a large shelter that has had huge outbreaks, sometimes hundreds of people with COVID. We've been using a lot of resources in settings like homeless shelters, like the jail, like long-term care, doing a lot of testing in those settings, a lot of follow-on. Getting vaccine in there opens up resources for testing, for public health intervention that we can use in other settings, and it really has the biggest impact to decrease our number of cases, the opportunity for spread, especially with variants on the horizon, and then getting it into the communities that have been hardest hit. And we can, people will probably have some questions about that because we announced the Protect Chicago Plus. But there is a lot of, even, I know individual people are just feeling very frustrated, and I hear you, and I'm sure there will be questions about that. But there is really good, important work happening in getting vaccine into these settings in Chicago that are driving a lot of our outbreak.
Got it. Okay, so I think we can turn to data now.
Oh yeah, we'll do a very quick look. I know people who have been following, are used to knowing how to do this. Chicago.gov/coronavirus, always your first stop for anything related to COVID. You can get to the dashboard off there. You can also get to, there's a vaccine tab. Please keep exploring that. A lot of your questions are answered on that. You can also get there directly on chi.gov/COVIDvax. Here's the dashboard for the day. You'll see our percent positivity down to 6.6%. We were at 16% at the peak of our second surge here, just a couple months ago. Getting really close to that 5%, which is where we most ideally want to be. And that's been dropping. You see a week ago, we were at 7.7%. That's been heading the right way. Really good news. Similarly, our daily cases, 675 per day. We're adding, again, that is above the 400 we ideally are wanting to get below, and even the 200 most ideally below. But a week ago, we were at 883, and at the peak of our second surge, we were averaging 2,400 with days over 3,000. So all of this data is looking very good from a control perspective. And the things that are doing that are mostly not vaccine at this point. It is all, it is the natural effect of people continuing to be careful, continuing to do the things that we know work. So that's looking really good. And in that context, restaurants were able to open at that 25% capacity. We're being very cautious here. And where we need to, I do think there will probably be some stricter limitations on some of this here in Chicago than maybe in place across the state. We're a very dense city. We know that we have the possibility, for more cases, for more surge, and we're being really careful and cautious, excited about this progress, but using a dimmer switch, right? So this is not COVID is over, we're done. This is still higher than we want to be, but couldn't be better in terms of the direction we're heading.
Yeah. And just seeing that line go.
Yes. Whew. Explore that data if you want to feel more positive about the way things are going in Chicago. It's one of the reasons I look at the dashboard every day is right now it puts me in a better mood.
Yeah.
So.
Okay, so let's dig into questions.
Yes.
We have so many coming in.
I'm sure.
Here's one that a number of different people have asked. Why can't we use the 34,000 doses per week to vaccinate CPS teachers?
Okay. I have been answering versions of this question pretty frequently. Yeah. So first, let me be really clear. CPS teachers, just like all other educators in this city, are eligible for vaccine as part of 1B beginning last Monday, 4 days ago. So there are people who are being vaccinated. If they are able to get an appointment at a pharmacy, for example, they have an appointment through their doctor, they are eligible for vaccination right now. That said, Right now, there are 750,000 people competing, and most of the vaccine, reminder, is at healthcare settings. And we have asked those healthcare providers to reach out to their existing highest risk patients. So people in their 80s and up, people with underlying conditions, people who probably are not so connected to the internet in all cases. They are calling, bringing them in for appointments, and our numbers are looking really good there. We're seeing a lot of older people getting vaccinated. We're happy about that.
And just to say, put a finer point on that, that group over 80 is the group where we've seen the highest mortality rate.
That's right. That's right. That's right. And so, teachers are eligible for vaccine, just like first responders are, just like people, in that whole group, as well as everybody over 65. But we also are delivering vaccine through employment settings. And there's a plan and a rollout for this. And CPS has shared some details of really what that will look like. There are already CPS folks getting vaccinated who are in some of those highest risk categories. And broadly speaking, in a couple of weeks, we also make vaccine available directly through the employer. So people can continue to get vaccine sort of in this way that there's just a lot of competition right now. But this is vaccine we direct only for employers. But we don't just do it for CPS. We do it for the other schools, right? Like through these education settings. And can we just do a quick thought experiment on this?
Sure.
So 34,000 doses a week. That can sound like a lot.
Mm-hmm.
In the first 6 weeks of vaccinating here in Chicago, if you set aside what we had to leave for long-term care facilities, which we can't really touch for other purposes, we got about 165,000 first doses of vaccine. There are 142,000 people who work in education in this city, approximately. And if you want to see these details, it's on the website. So literally, with how quickly we're receiving vaccine, if we were like, let's just get all the educators done, we would stop vaccinating everybody else for about 5 weeks. If we stop vaccinating everybody over 65, stop pushing it into the correctional settings, our highest risk settings, and said we're just going to do educators, we could probably get through the educators in the city in about 5 weeks. However, that would give us 5 weeks of vaccinating people who, frankly, although they are critical for we know how important schools are, that's why they're in 1B, we wouldn't be actually vaccinating the people that will get us past COVID as a city, right? Mm-hmm. And so we're balancing a number of these things. We want to make sure the highest risk people and the highest risk settings are also getting vaccine. And so we balance this so that, we've been doing, for example, first responders, right? More than 20% of police, fire have been diagnosed with COVID. It's a very high risk setting. You can't have those mitigation things in place. Mm-hmm. We want to make sure that these settings that can't have the mitigation are also able to access vaccine. So 100% teachers are in there. We want them vaccinated. We've got plans. We've got vaccine that's being directed toward them, but we can't stop the vaccination in all of these other settings. It is one stream and an important stream within that, but that's just the amount of vaccine that we're receiving. And the hope, and what we've really shared with CPS and others, is that you get a dedicated stream of vaccine going. As we get more vaccine, all of these streams are able to open up some more. Mm-hmm. And everybody's in agreement that, for example, we'll want to be doing some prioritizing for, schools in our highest CCVI, our highest COVID vulnerability index. There might be some possibility of thinking there first. There's ways to sort of prioritize this. But at the health department level, we don't distinguish between teachers and educators in all of our settings across Chicago, and we work to really make vaccine available through large employers.
Yeah. An interesting thing about what you just said in terms of the risk for exposure.
Yeah.
What we also know is that the educators who are currently working in schools are at a lower risk because of the mitigation strategies that are in place.
Yeah, right? and that's been one of the more, and I know this has been a major point of discussion, but it is honestly, one of the areas where we have the very best data and examples here in Chicago, across the country, even around the world, that where you have masking, social distancing, pods, these things in place that have nothing to do with vaccine, this is all pre-vaccine, we don't see increased risk of transmission in schools, and they don't drive community outbreaks. And we didn't know that a year ago, but it is something that we know now. And, you know, increasingly, I think, you know, the CDC has been really doubling down on this. Dr. Fauci was on Good Morning America this morning really talking about that. And we want to push vaccine into these settings, but I don't want people to think that the vaccine is somehow necessary to make that setting safe. Because what we have seen is that with that good mitigation, those settings do not put people at increased risk of COVID exposure, and that's good news, right?
Yes. Yes.
So we're focused on getting these folks vaccinated, just as we are getting these other groups vaccinated, but we can't pull vaccine away from seniors, from some of these even higher risk, to sort of put, you know, all of our vaccine or even most of our vaccine into one of these settings. We got to hit all of them at once to continue to see progress and not give opportunities for COVID to take hold.
Got it. Okay, so let's keep going. This is a question from Elizabeth Krolak. From Facebook. Can we get seniors their COVID shots by having medical professionals administer door to door in their wards? They can't get to the centers, and they can't navigate the internet. So what are we doing about these accessibility issues?
Yeah, absolutely. So like I said, so door to door is not really an option with the vaccines that we have right now. Let's just maybe start from that. These are vaccines, as we've talked about, that need either the ultra cold or the frozen. There's dilution that has to happen. There's drawing up. There's a lot of actually technical work that we do. You have to make sure you are monitoring people for at least 15 minutes, and in some cases 30 minutes post-vaccine. You've got to make sure that you have all the equipment in place. You know, unlikely event somebody has an allergic reaction. These need to be done at this point, really, in a setting. These are the controlled settings to make sure that our vaccine operation is safe. So we can't go door to door actually giving vaccine. But there's a few things that are happening here. One is, like I said, most seniors at this point, and these are really our oldest Chicagoans, so it's not like there's enough for everybody over 65, but we've got hospitals and healthcare workers and clinics calling their existing patients. Proactively, not waiting for them to call, not waiting for them to do the internet, booking appointments for them to come in to their regular clinical setting and get vaccine. And that really is a best practice, because they can then, you know, talk to their provider. They're in the space they know, especially in areas where we may have some more vaccine hesitancy. You're able to like have that conversation. And your doctor or your doctor's office, who knows you, is sort of reaching out and saying, you should get a vaccine, and here's why. So that's one thing. But also, you know, I think we could talk a little bit about the Protect Chicago Plus.
Yes.
Like, does that sound good? So there are, you know, as we announced on Monday, there's been a lot of work with the epidemiology team to identify some neighborhoods in Chicago that are just higher risk. More people are not connected to care, more risk factors, harder hit by COVID, and those map really well onto the parts of the city where we're just seeing a lot less COVID uptake to date. And some of that is, vaccine uptake to date, thank you. And so, you know, there's some strategies for bringing vaccine into there. Do you want to maybe talk a little bit about that, and then we'll chime back in?
I'm so excited about Protect Chicago Plus, but to the point, Elizabeth, we've been working with community partners who know their communities well. A lot of these partners have their own lists of seniors that they're proactively calling as well. We're starting to map where independent senior living facilities are, so that we can think about how we could bring a strike team to those facilities where we can set up, in the event that we can set up a controlled setting that's going to work for vaccine. And then we're also talking about outreach workers who are in those communities already, going door to door to have the conversations that are needed and sign people up.
Exactly.
So to get them set up with their appointments by doing that. And then there's some work too with our partners who already have their own kind of hotlines and call centers to use those call centers as a place for seniors and other people to call in and get information and also get assisted with making appointments.
Yeah, so this isn't door-to-door giving needles, but some of this door-to-door work, which we already built the groundwork for as part of Protect Chicago before we had vaccine available, getting people signed up, and then there are, the potential for sort of dedicated vaccination opportunities for those individuals. So yeah, it's all happening, and this doesn't, vaccine again available to everybody, but recognizing that there are some settings, and older people need special attention for sure. Yeah. And we're doing it.
Yep. Okay, Val Spalding from Facebook. Why are people dying from the vaccine after they take it?
So people are not dying from the vaccine after they take it. Let's just start with that as a baseline and then talk about why, some of what is probably happening behind this question. So as a reminder, there are about 1 million of these vaccines being administered every day now across the U.S.
Wow.
Between first and second doses and ramp up and
just the U.S., not the world.
Just the U.S.
Uh-huh.
Yep.
That's a lot.
It is a lot, and this is every single day, just like it's ramped up here, it's ramping up across the country. I think additional resources are also being put toward this, which I'm thrilled about, which will let us do more, and then more vaccine will also make this the most important thing to ramp it up. But there are a lot of people that are being vaccinated at this point, and when you are vaccinating so many people, there are people who will die. Not from the vaccine, but after receiving the vaccine. We're prioritizing people literally who are in their 90s. In the case of long-term care, we've got people getting vaccinated who are over 100 years old, people that have a lot of underlying conditions. And it is true that people will continue to have heart attacks and get hit by cars, and all of the things that people die from remain possible. It is also possible, as a reminder, that the vaccine, especially after that first dose, it is not 100% protective against COVID, and that's, getting into these settings is the highest. But there is not a rash of people who are being vaccinated and then dying as a result of that vaccine. If that were the case, this vaccine, there is post-review every time there's a serious adverse event that happens, after. That's why we have all of this post-monitoring about side effects and concerns. Just yesterday, the ACIP, which is the CDC's advisory group, looked again at safety data. I refer you, it's all available online if you want to kind of see, every bit of it, if you want to see some of what's getting presented there. But we continue to have really, really excellent safety data related to this vaccine, not seeing unexpected things. And certainly if you were seeing people, that there was a significant link between people getting this vaccine and people dying, that vaccine would not continue to be administered, of course. There were even people who died in the trials when these vaccines were being tested. And again, remember, this is why we have an arm that gets the real COVID vaccine that's under investigation. A group. Yeah, we call it an arm of the trial. Sorry, a group. Yeah, that's the technical term. There is a group. Half the people basically in the trial get the real COVID vaccine, and half the people get a dummy. They get an injection, but there's no vaccine in it. And that's because you can follow those groups forward and compare. And I posted a video, sort of science behind the vaccine, about this last week, so you can find it online. But you compare, and more people died in the trial in the non-vaccine arm, in the dummy placebo arm, than in the COVID arm. And then they investigate anybody who dies, a lot, let me tell you, in a trial, and see, is there any link here? So,
and there were some, there were other, not the vaccines that we're talking about, but there were other medications and things that people were following, and if there was a concern for safety, those things were just shut down.
Yes,
right?
That's right. And this, anytime, we've not seen, the good news, none of the vaccines that have been under study here in the U.S. have shown safety concerns, right? Merck, actually, if people saw, Merck stopped moving ahead with its 2 vaccine candidates because the efficacy was not good enough. It wasn't protective enough. This is why we do the trials. But
we have a high standard now.
We have a very high standard. Well,
right?
yeah, and they don't have to hit 95% to be approved, but they do need to hit a good level of efficacy. And if the vaccine doesn't have a good level of efficacy, but safety comes first. You see any safety concerns at any stage, you don't keep moving ahead with that vaccine, and that would include post the authorization. There's continued monitoring that happens.
Yeah. Don't you fill out something every day?
Yep, so people who get vaccinated, they're not required to, but have the opportunity. It's a QR code through your cell phone. You get a text and you say, these are my side effects, these are my concerns. Anything that's concerning, actually the CDC is part of the direct investigation there. And then there's additional work where providers have to report any concerning what we call an adverse event, something that sort of comes to any kind of medical attention, whether they think it might be related to the vaccine or not. That's part of how we follow the allergic reactions, which again have not been crazy high. They've gotten a lot of attention, and certainly we want to make sure that we're following them, but it's not that we've seen, millions of people with allergic reactions, but every time there's a reaction, every time there's any concern, it gets reported in, and there's a large team of people that follow up on those events and just look to make sure that there's not additional safety concerns or other labeling that's needed.
Okay. From Donna Leonard. Once I receive my vaccine, will I be able to travel without having to test before return or quarantine upon return?
So not at this point. So as a reminder, the vaccine is still, as we keep saying, not widely available, and we still have, although, I think as of today, 1 in 23 Chicagoans have already started and gotten that first dose of vaccine. That is nowhere near a level where we would be thinking about pulling vaccination numbers kind of into those other mitigation strategies. So even if you've been vaccinated, nothing changes for you. Not only do you have to keep wearing the mask and all this, you do need to continue to abide by, travel guidelines. If we had to go back under a stay-at-home advisory, you would still be part of that advisory. We don't make a distinction at this point between the vaccinated and unvaccinated. As time moves on and we start to see more impact, there will be some of this eventually probably starting to play a role. But before vaccine is widely available, it is not either sort of possible in terms of what does this look like, but it's also not fair,
right.
Frankly. And so we continue to have everything apply. Vaccine is an extra piece of protection, but our most important protection are the mitigation things that are already in place. Good question.
Here's another good question from Elena Levy from Facebook. I'm hearing it's okay to wait 6 weeks between doses versus the original recommendation. Is that true? Can you mix vaccines, the Moderna or Pfizer for the first dose, and then follow up with the other, Moderna or Pfizer for the second?
Okay, so let's take the second question first. The answer is no. You need to get the same vaccine for the first dose and the second dose. Need to get the same vaccine for the first dose and the second dose, yes. And there's a lot of behind the scenes work where part of the reason we register you and make sure we know it's you, and all the way down to the exact vial that you got, to make sure that in the records we know which is the first one, so that when you are getting your second one, we can check that and make sure you're getting the right one. The best practice, and absolutely what we expect to happen 99% of the time, is for people to get that second dose in the exact same location that they got their first dose on time. So we are very strongly encouraging, and some of this as the tech has been building, et cetera, we are very much encouraging providers, whether those are hospitals, pharmacies, clinics, our own pods, et cetera. We want to basically be in a spot where both of those are just getting scheduled at the same time. So if I am getting Pfizer on a Monday, 3 Mondays later, I'm getting scheduled for that second dose. If I'm getting Moderna on a Thursday, 4 weeks later, I'm getting scheduled for that Moderna dose. It helps us from a planning perspective, because remember, behind the scenes, although there's a lot of attention on the first dose, boy, that second dose is also really complicated from the logistics and the distribution. Pfizer, for example, which we thought would have 5 doses in it, ended up having 6 doses in it, and so people have in some cases been able to administer more vaccine than we expected. We've got to make sure we're coming along behind with enough vaccine to support. There's a whole second piece of distribution and appointments that is happening that has to accompany the first dose. So it is part of what makes this logistically challenging. So on the question of can you get it later, all vaccines have a recommended way to administer them. And the recommended way, which is set by the CDC ACIP, is that spaced dosing. Certainly, there is a window of a few days that is not a problem. Like, I think I got my second dose, 3 weeks and 2 days or something later. Fine, not an issue. If people do miss that second dose on time, we would still want them to get the second dose. However, from a logistics standpoint, how much demand there is for this vaccine, et cetera, we see people start waiting. Number one, that's not how this vaccine was tested. So we want people to get this vaccine in the way that the safety and efficacy was done, because then we can be sort of honest with you about your level of protection. I don't want people saying, oh, I'll just wait, I'll do it in 2 months, I'll do it in 3 months. It would be better to get it late than not to get it at all. But the longer you wait and you try to mess with it, the less likely it is that we are going to be able to make sure that that second dose is available for you kind of at the time that you feel like is right. So we want people very much to plan, and that's on the provider side as well. And again, working on the pieces of this to get that second dose on time at the same location. And definitely, you got to get that the same second dose. You can't get one Moderna and one Pfizer, and that will continue to be true even if other vaccines are approved.
No mixing and matching.
No.
Susan Villanueva from Facebook. If you took Tylenol before your vaccines, does it affect effectiveness?
No, this comes up a lot, even around regular vaccines. There's sort of a theoretical that Tylenol less so, but sometimes people think that the ibuprofen, for example, that there's some theoretical that it can kind of decrease an inflammatory response. Would that, would that in some way tamp down the immune system? Yeah. Really, we don't recommend taking it in advance. Like, don't take some Tylenol or some ibuprofen in advance. If you have a side effect that you...
So, like, if your arm is sore, you might take it afterwards.
You could take it afterwards. If you had a sore arm, particularly, most people are not having any, serious side effects at all. But if somebody is really feeling badly, if they're having a fever, if they're not feeling well, yes, you can take Tylenol, you can take ibuprofen. That will help, and it's, again, this is just your immune system responding to it. But I wouldn't recommend just taking it sort of proactively. I would take it. I had literally no side effects. And there are plenty of people who are having literally no side effects from it. I think on balance, it's not going to hurt you if you do. But I would recommend not taking it ahead. And then if you do have a side effect and you feel, like a headache that you would normally take something for, you can go ahead and take that.
Okay. Belinda Jackson from Facebook. I will be getting my second dose on Saturday. Will this vaccine be yearly? Are we going to have to re-up next year?
So we don't know yet. And this is really because of this variance question. So right at the moment, this vaccine looks good. Okay, every variant that has been detected, the vaccine continues to be effective against. It's really different than the flu vaccine, where we're not just talking variants, which are slight differences, we're talking whole different strains. If you get enough variants, enough mutation, you would create another strain potentially of COVID. Flu has all these different strains, and every year we have to see there are so many different strains of flu. You actually see which are the strains that are circulating the most. You make a new vaccine every year to cover all the vaccines, the strains that are the most prominent. It's part of why the flu vaccine is not as effective as as protective as the COVID vaccine, because sometimes there will be strains that turn out to be more important that the vaccine is not matched as well against.
Yeah.
So
a variant, the variant that we're hearing about isn't a whole new,
it's not a whole new
COVID.
Strain. It's not a whole new strain. That's right. And this has been one of the things. I think I'm going to do my next Science Behind the Vaccine sort of about mutations and variants and strains, because it is something that people probably have not thought a whole lot about before this. Yeah. But at this point, what there is
kind of like arm and group.
Yes.
Like, that's not our talk.
Yes, exactly.
So when we hear variant, it's like the whole new COVID out there.
That's right. And variants, certainly. I mean, everybody shares concern about these variants. Like, I don't want to minimize it in terms of the fact that, COVID has been spreading like wildfire. And every time COVID spreads, naturally, we see potential for mutation. Viruses mutate all the time. It's not an issue. It's been actually very good news that we haven't seen a whole new strain. Just starting to see some more of these variants. One of the new variants, the one that was first detected out of South Africa, there was a sign that the Moderna vaccine is a little bit potentially less. You don't get as much of the neutralizing antibodies. It's still protective. So I don't want people to think it's not protective, but it was one of the first times that, Moderna's been testing it, and you still had enough antibodies to be protective, but it wasn't as much as they were seeing against the other strains. So there is already Moderna and others, well at work around if you needed. The good thing about the technology of those vaccines, it's not as hard to kind of, if you needed to make an adjustment or think about something down the line. But right now, broadly, I think the feeling is still that the vaccines we have, given how much spread this virus has had, it has been, I think, actually in a lot of ways remarkably stable.
Yeah.
And just because you have a lot of variants, it doesn't necessarily that are more infectious. It doesn't necessarily mean that the vaccine won't work. Like measles, right?
Yes.
Very, very infectious. We got a question the other day about what if these variants kept emerging that were more and more infectious. It's very infectious, but the vaccine works beautifully. There's a vaccine that's 95% protective against measles. It's been really good. So we're still learning about this, but I think it would be something that maybe you could need a booster, et cetera, et cetera. If we can get past COVID broadly, if we can get this down to a level that is not sort of impacting society, widely spread, get to some of that herd immunity, which I'm feeling confident we can do with the vaccines that we have right now, as long as we're thoughtful about where they go, then I don't know. We'll find out is sort of the bottom line. But the vaccines...
It's so interesting. Because the research is following forward, right?
Yes.
Like it's just continuing and continuing.
That's right.
And even as these new things come up, they're being studied.
They are. Oh yeah, 100%. There's so many people studying these, and literally every time that every time the virus gets its genetic fingerprint taken, its sequencing, that's looking for the mutations, that's looking for variants, those get uploaded into a worldwide database. So there has been work here to make sure it's not just like an individual lab that's looking at this. This is a worldwide issue. And so one of the things that I think was good here was that very early on an expectation that this kind of analysis gets shared across the world. So, right now, news continues to be great about this vaccine. The most important thing is taking it, having that predictable protection, and then we'll see a year from now, 2 years from now, 3 years from now, are there additional strains? Do we need to do more with that, or do we not? And time will tell.
All right. We just have a little bit of time left. We have a question from Faye State. That's a familiar person to us. How effective is the Johnson & Johnson vaccine? Is it also being tested with 2 doses?
So I definitely cannot answer the question of how protective is the Johnson & Johnson vaccine, because the Johnson & Johnson trial has not completed, has not gotten enough information to be able to be presented to the FDA. And just as a reminder, this is the other side of the coin of like, is this moving too fast? Like, you can't speed up the trials either. You have to go through all of the same safety and effort. They have to run their course, and again, the way these trials work, you actually wait for a certain number of people to get COVID, and then you unblind the trial and you see, if 100 people got COVID, hopefully 95 of those people were in the dummy arm, the placebo arm, and 5 were in the vaccine arm. But until those people get COVID, and until the FDA has really said, different from some other places, they want to see at least 2 months of that safety follow-up before, until they'll look at it. We do expect Johnson & Johnson likely to be able to finish that first stage pretty soon and be able to present that to the FDA. And just as a reminder, once that happens, we'll have that preliminary information. But then the external review panel, the scientists, the FDA, they take this data apart, soup to nuts, look for any problems in it. There's a major process by really wanting to make sure before they would give that authorization that data is truly showing appropriate safety and protection. And that process takes at least a couple of weeks, even when it's going as quickly as it can. The CDC also and ACIP take a look at it in terms of the recommendation for administration. Who should this go to? All of that. So my understanding, again, this is all, nobody has officially seen this data, is that they have been looking at both 1 and 2 dose regimens. One of the things we're excited about with the J&J possibility is if the data is good on this, having a 1-dose vaccine would be amazing. And especially, we also understand that it only needs to be refrigerated as opposed to the frozen or the ultra cold, both of which make our logistics much, much harder. So everybody's excited about that one, but we don't have the data yet. Not yet.
Yeah, and it's kind of ironic because many places like us have come out of that second surge, right? So that probably impacts the length of
yes. Ironically, that's right. One of the reasons why these trials were able to sort of be done very quickly, unfortunately, was that we've had so much COVID spread. So as COVID risk goes down, the US, ironically, has been a very good place to develop COVID vaccines because we've had such a lot of COVID circulating. So as COVID comes under better control, hopefully across the world, it actually does slow down the vaccine clinical trials. But safety and efficacy, you got to have those. We don't want a vaccine that is not safe and effective.
All right. I think we are down to our good news, Dr. Arwady.
All right. Let's see. What would be some good news? So one, and just to tie us back,
yes.
One last point I wanted to make was that you don't lose your eligibility when we move on to the next step. So 1A, which included our healthcare workers, first and foremost, people in long-term care, remain eligible, and we really encourage anybody who has been eligible in 1A, if you've now decided that you want to get that vaccine, please do that. Our hospitals, our healthcare centers are working hard to encourage people to get that vaccine. We want those settings to be as safe as possible for the workers and for the patients who come in. And we've seen really good progress there. Loretto Hospital, which is the hospital where we ceremoniously launched our vaccine effort back in December, our first vaccine in Chicago. The head of Loretto Hospital called me yesterday and said that 90% of their employees have been vaccinated, which is amazing. So cheers to them. Cheers to so many of these settings, especially in our hardest hit communities, that are doing just a great job getting people vaccinated. He told me an anecdote too. He said, there was a 85-year-old who had come in, because they are also vaccinating community members. This is in Austin, who said, 85 years ago, he'd been born at Loretto Hospital, and today he was coming in and Loretto Hospital was saving his life again. And just, nice stories. And patience, please, for all of you who are anxious to get vaccine. We'll be sharing some more information next week as more appointments become available. We do want to have some ways that people can sort of centrally see where some more of that is. We just have not had appointments available. The city pods have been booked up, with the healthcare workers, starting to get some first responders and others kind of in there. Yeah. But there will be, some more good news coming on that front. And each week we do receive more vaccines. So I want, if people have been sort of refreshing on those pharmacy websites, et cetera, just honestly, there is not more vaccine this week. Like, it's all gone up. 99.9% of the vaccine that Chicago has received has been pushed out. But each week more does come in. So good news on that, although we hope the numbers get even bigger. I think also, as a reminder, Chai COVID Coach is your way to sign up if you just want to make sure you're getting direct texts, et cetera, just with that kind of information. There are no more there are no appointments available sort of to the public. That doesn't mean that healthcare providers are not continuing to reach out and make those appointments for existing patients. Reminder, checking with your hospital, your clinical setting is a good place to start there, but really it's just patience at this point, honestly.
Yeah. And the website has such good information on it. And to your point about healthcare, we know there are a lot of unaffiliated healthcare workers, our home health aides. We also have, dentists in the community, and there's a tab for healthcare on the website.
There is. There's a tab for healthcare providers, for settings that still want to sign up to be vaccinators. We're pushing lots of those through every day, and that's been going really well. We've got hundreds, more than 400 sites now across Chicago that are vaccinating. And so, and that's our infrastructure, that as more vaccine, hopefully, as Johnson & Johnson, hopefully, or AstraZeneca, and as the Moderna and Pfizer ramps up even more, we've been having good conversations with the county, with the state, with the federal government about how to grow some more of this, how to get some more support. So, this is going to keep ramping up. I feel good about the way that it's heading. I think the last thing is this Together We Heal virtual summit. It's tomorrow. It's from 10 to 12:30 p.m. Do you want to say anything about it?
This is coming out of our Office of Racial Equity and Justice, which is led by Candace Moore. Really excited to be kicking off a long-term, year-long focus on racial healing. It will feature a conversation between the governor, the mayor, and the head of the state's health services department. So really want people to join. You can, you might have...
I do. Chai.gov/Together We Heal. Tomorrow, 10 a.m., and it runs from 10 to 12:30.
Open to everyone. We know that there is so much collective, historic trauma, and this is just a movement to lift up all the work that has already been done across Chicago in communities, in small groups, in large groups, this effort to really turn towards healing and to do that collectively. And so this is just lifting up all the work that's been done, but also, encouraging us and asking folks to help us understand how we can deepen and broaden that work.
All right, so do tune into that tomorrow. And otherwise, if we didn't get to your question today, every single day we are adding more information to that website, chai.gov/COVIDVax. You can also get there off the vaccine tab from the regular page. All kinds of data up there, all kinds of information, lots of guidance and websites, and much more to come. So thank you to everybody for tuning in. Keep doing the things that you know work, and help us all protect Chicago.
That's right. See you next week.